The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I'm finally getting around to doing this nutshell episode about diabetes. The previous ones have covered hypertension and hyperlipidemia, but I think diabetes is probably the most complicated, probably the hardest to stuff into a nutshell. I've been avoiding it, I guess, for that reason, because the more I think about what I should say, the more I think that I ought to say. It's just a big topic, and my goal with these nutshell episodes has been to kind of take big topics and distill them down into very useful little tidbits. I don't know how good of a job I've done of that, but maybe someone's found it useful. I've noticed that these episodes where I talk about clinical topics like this actually get more downloads or listens or whatever you want to call it than the non-clinical episodes. So hopefully that means you guys are getting something out of this. For the information in this episode, I'm going to use the American Diabetes Association Standards of Care for 2025, which by the way is 359 pages long. It always drives me nuts when the different professional societies have a little bit different guidelines than one another. I know I've talked about that on here before, but I'm just going to pick one and stick with it here. So hopefully everybody kind of knows what diabetes is. It just means that the cells cannot get the glucose that they need to operate, whether that's because of insulin resistance or because the pancreas is not making enough insulin or any insulin. You can diagnose diabetes by looking at the A1C. Hemoglobin A1C greater than 6.5% is considered diabetic. Fasting glucose greater than 126 milligram per deciliter is considered diabetic. And fasting means that they've not eaten anything for at least 8 hours. You can do a glucose tolerance test, and in that case, a 2-hour postprandial glucose of greater than 200 milligrams per deciliter is considered diabetes. Or if you have somebody who has sort of the classic symptoms of hyperglycemia, polydipsia, polyphagia, polyuria, that sort of thing, if they have symptoms like that and their plasma glucose is greater than 200 milligrams per deciliter, they have diabetes. In our practice, we tend to just go by the A1C. We check everybody's fasting glucose as part of the metabolic panel at all their routine visits. And if we see that it's trending up or it's consistently like over 100, then we'll start adding on the A1C. We tend not to do the glucose tolerance test. That's really kind of a lot to ask a patient to do, to basically take half a day to come drink some sugar water and see what their blood sugar does, when you can just spot check the A1C. And there's a downside to that. The glucose tolerance test would more clearly show you that you have insulin resistance before they actually develop diabetes. And you can kind of surmise that by looking at a person's glucose. If their glucose is consistently whatever, 110, 120, 130, but their A1C is still normal, that probably means they have some insulin resistance going on. I had one patient that when I inherited him was on metformin, and his glucose was just excellent all the time. And he was on a very low dose of metformin, and it seemed like there was some question about why he was put on it in the first place. So I said, well, let's just stop it and see what happens. And his fasting glucose was normal, like under 100 every time we checked it as we went along. And then recently he came in and said, I want to really make sure that I'm not diabetic. And so I flipped back through the glucose readings and I'm like, no, you're good. Your fasting glucose has been fine even since we took you off the metformin. So I think you're good. And then I checked his A1C, and damned if it wasn't like 6.8 or 7 or something. Like, he was totally right. So that system of watching the fasting glucose and the A1C, not perfect, but generally you can see the A1C kind of trend up over time in your type 2 diabetics and realize when they cross the threshold. Of course, we differentiate diabetes into type 1 and type 2. Type 1 meaning that you've had autoimmune destruction of the islet cells in the pancreas that make the insulin. Type 2 meaning more like you develop insulin resistance over time. For a long time, we thought type 1 starts in childhood, type 2 starts in adulthood, but it turns out there's more overlap. It's more complicated than that. You can have children who develop diabetes who are actually considered type 2, and you can have adults who develop diabetes who really are type 1. And the way you differentiate between the two is by checking the different antibodies to the islet cells. I don't really do that in every new diabetic diagnosis, but you definitely can. Usually, honestly, when I think about doing it is when I have a person who just doesn't look like a type 2 diabetic, right? We think of type 2 diabetics as being overweight, And so when a thin, otherwise healthy person develops diabetes as an adult, that's kind of what triggers me to go, I wonder if this is type 1. And maybe that's not fair. Maybe I should think that too of people who are overweight, but that's just what triggers that thought in my brain. As far as which antibodies to check, if you're going to order these tests, your choices are glutamic acid decarboxylase 65 or GAD65, islet cell antibodies or ICA, insulin antibodies, antibodies to tyrosine phosphatase related islet antigen 2, also known as IA2 or IA2 beta, and zinc transporter 8 antibodies or ZNT8. Our local hospital system has a panel that's called Diabetes Mellitus Type 1 Evaluation, Serum that includes all of those things, so you just have to order the panel. If you're in a situation where you need to pick specific ones to order, the one you want to start with is the GAD65. Those antibodies can be negative in about 5 to 10% of people who actually do have adult onset type 1. So if we were in that situation with a patient that we thought might be type 1, but the antibodies were all negative, we would probably still start with a trial of non-insulin therapy and just see how they do. If the non-insulin medications don't really work that well, then that might still push you to think that maybe they're type 1. So in that situation, we'd go ahead and put them on insulin. And then after they've been on insulin for a while, actually like 3 years officially, you can do a C-peptide test, and that'll tell you how much of their insulin is endogenous versus what they're taking. But by far the more common situation is that you have a patient whose glucose has been trending up for a while. They finally kind of crossed the threshold of becoming diabetic, and then you end up having to start them on medication. Once in a while, you'll get somebody who shows up to the hospital sick, and it turns out they have raging diabetes that nobody picked up on. Generally, these are people who have not had primary care, haven't gone for their routine screening and all that. And sometimes you'll see those patients leave the hospital on insulin. There's a thought that if the A1C is really super duper high, you should just go straight to insulin to get it down. That sounds good in theory. In practice, it's kind of hard to get somebody who didn't even know they were diabetic to start doing blood sugar checks and giving themselves shots and all that. I tend to lean more towards just trying oral medication, almost regardless of the situation, and seeing how they do. Or you can run into other situations that might complicate the matter. I saw a patient at the free clinic the other day that was in that kind of situation. She had gone into the hospital and got a new diagnosis of diabetes and left with insulin, but she is a resident of an inpatient drug rehab facility where they kind of frown on the use of syringes and needles. So she was saying that she was having to hide from everybody to go check her sugar and give herself shots. And it wasn't even clear to me if she was allowed to have that or if she had snuck it in or whatever. But obviously that was not the right patient to put on insulin. And just in general, I think of insulin as a last resort. Maybe I shouldn't think of it that way, but you're asking the patient to do a lot if you're going to make them start sticking their finger to check their sugar all the time, giving themselves injections, whatnot. And I would say that most people do not want to do that if they don't really have to. So for just about everybody with straightforward type 2 diabetes, we're going to start with some kind of oral medication. The choice of which medicine you start with has gotten a little more complicated these days with the introductions of some of our newer medications, the SGLT2 inhibitors and the GLP-1 agonists. But usually metformin is still fine to go to as a first-line medication. It works by increasing the body's insulin sensitivity, decreasing how much glucose the liver produces, and also reducing how much glucose the intestine absorbs. Very commonly, it's going to cause some GI side effects, namely diarrhea. I usually start with the extended release version. It tends to not have as many problems with GI effects, tolerability. Really about the only common reason not to start metformin would be if they already have some issue with kidney function, because it can be hard on kidneys. You got to be careful with it if their GFR is between 30 and 45, and then with a GFR below 30, you would not use it at all. And you do need to stop it if their GFR drops below 30 in the course of treatment. In a lot of people, just metformin is sufficient to keep their sugar down. And obviously, we want to encourage lifestyle modification, good old diet, exercise. I find myself sort of taking it for granted that people know what foods to avoid if they have diabetes, but we really should not take that for granted. Obviously, there's a ton of information out there just on the internet about diabetes diets. I tend to go with the Mayo Clinic handouts for things when I have to give people information like that, so that's always a good place to start. If you can send people to a diabetic education class, that's phenomenal. One of our local pharmacies does that, and the hospitals around here kind of hit or miss. Sometimes it seems like they're doing programs for that and sometimes not. But I guess just because we think about it so often and have learned so much about diabetes, we just take it for granted that people would know not to eat concentrated sweets and simple carbohydrates and know what foods to avoid. But that's not always the case. So make sure that you take the time to educate your patients or at least kind of gauge their level of understanding of what they need to do with diet. And once in a while, you'll have the rare patient who is super motivated to keep their glucose down and can do it just with diet and exercise. And if that's the case, hey, fantastic, more power to them. If you run into a patient whose A1C has crept up, maybe they're at 6.8 or 7, and they go, well, can I have another 6 months to try to get it down and work on it? Absolutely. If there's not some pressing reason, if they don't have crazy high cardiovascular risk or something, sure, let them try. It takes 3 months for the A1C to show a change in what they're doing. So typically you don't want to check it any more often than every 3 months. So after this is where it kind of gets hairy or tricky or fun, or however you want to look at that. We've diagnosed the diabetes, we've put them on metformin, we've encouraged diet, lifestyle change. So they do all that, they come back in 3 months and their glucose is still too high. What do we do next? Okay, what are our other choices for medications? We have SGLT2 inhibitors. These are the Flozin medications. SGLT2 stands for sodium glucose cotransporter 2. Common brand names are Farxiga and Jardiance. They work by making you pee out sugar. They reduce the amount of glucose that the kidney is able to reabsorb. It also affects sodium in the same way, so you got to remember that. These medications have multiple benefits. They're good for your kidneys, they're good for your heart. We're seeing them actually being used in heart failure and kidney failure, or to try to prevent kidney failure. This is one of the medications that everybody's super excited about, that they continue to find more and more roles for. And I think that's the main reason why the thought about just immediately starting with metformin has kind of changed, because these drugs in particular, along with the GLP-1s, just have so many other benefits that there are a lot of situations where you can see why you would want to just jump to one of those medicines instead of starting with metformin because of all the other benefits. Because metformin doesn't really have that positive effect on kidneys, heart, overall mortality, all that sort of thing that you get with these newer medications. And obviously with the newer medications, you're going to run into a cost issue. These are still new branded medications. And unfortunately, a lot of people's insurance won't pay for them, or they want them to go through trials of the older, cheaper medicines first. So you still may run into that. So the next class of medicine is the GLP-1 agonists. These are the ubiquitous medicines that everybody seems to want to be on for weight loss. GLP stands for glucagon-like peptide 1 receptor. So common brand names there are Ozempic and Trulicity. And then you have the tirzepatide brand name Mounjaro that hits a second receptor, the GIP receptor, which stands for glucose-dependent insulinotropic polypeptide. These work by increasing insulin sensitivity, decreasing the secretion of glucagon, increasing the secretion of insulin, and delaying gastric emptying, which has the practical effect of making people feel full all the time and not wanting to eat. And they are fantastic for weight loss. They also have some benefits for kidneys and heart. We're seeing people do all kinds of crazy stuff to try to get on these medicines for weight loss. I don't think I've ever heard patients come in hoping they're diabetic before so they can get on these medicines. Of course, a lot of people are getting them through weight loss clinics where they get the compounded version that's much more affordable. And then you have these crazy places that'll sell you the research peptide version that's not actually supposed to be used for humans. But apparently just anybody can order those and kind of mix your own at home, which sounds absolutely crazy to me. But I do have at least one patient I know of that's doing that. And I mean, I don't condone that, but you do you, whatever. So along with the SGLT2 inhibitors, I hope that we will see these become more affordable because so many people would benefit from these. The other of the newer medications are called DPP4 inhibitors. These are the gliptin medications. Common names are Januvia and Onglyza. DPP4 stands for dipeptidyl peptidase 4, and by inhibiting that, they slow the metabolism of incretin, they increase the synthesis and release of insulin, and they decrease glucagon levels. These are kind of like the least preferred of all the newer ones. They don't have that great of an effect on blood sugar, and they don't have the other cardiovascular and kidney benefits of the GLP-1s and the SGLT2s. So they're like the least impressive of the newer medications. Other options, older medicines, you have pioglitazone, brand name Actos. This is a thiazolidinedione that works to increase insulin sensitivity. This is a pretty decent option. I tend to use it if I have a patient that I need a second agent for and the newer medications are not affordable, not covered, whatever. This is usually the one I go to. It tends to be pretty well tolerated, and it does help get the sugar down, so I think it's still an oldie but a goodie. The other choices are the sulfonylureas. Common generic names are glipizide and glimepiride. Brand names Amaryl, Glucotrol. These are definitely your least preferred agents out of all of them. I think of these as working by squeezing the pancreas. They just stimulate the islet cells in the pancreas to make more insulin. And the big problem with that is that they cause hypoglycemia. Really, none of these other agents are going to cause significant hypoglycemia, but these are the ones that'll make your patients drop too low overnight, wake up with sugars in the 60s or whatever. They're kind of less predictable as far as the effect they're going to have. And again, they also don't have the kind of secondary benefits that you get with the newer agents. So this is definitely like your last choice. You want to stay away from these if you can. I personally feel like we're at the point where they should just take them off the market. But that being said, I do have a lot of patients who take them. Number one, because the physician I took my practice over for seemed to use a lot of these medications, so I just have several patients that were already on them. And then again, we run into this stupid situation where the insurance won't pay for the medicine that you actually want to use, so you find yourself stuck in a situation where that's your only choice of a medicine that the patient can afford. So if you do have to use those, you really want to warn the patient about hypoglycemia. I would say if they're not checking their sugar at home, you should probably get them to start doing that if you're going to put them on a sulfonylurea, just to know if they're having those hypoglycemic episodes. So those are all your non-insulin medication choices. There are several different medications that are combinations of those medicines. You can get a metformin combined with an SGLT2 or a DPP4, or there's all different sorts of combinations that you can use. And I'm a fan of less pills. If you can get them on a combo, that's fine. My personal little protocol that I am in the habit of doing as far as the progression of these medications, normally I'll start metformin first. I'll add an SGLT2 inhibitor if I need a second agent. If I need a third agent, I'll try to do the GLP-1. Of course, some people want to go straight to the GLP-1, and I think that's fine. After those, I'll use pioglitazone, Actos if I need something else for glucose control or cost reasons. After that, I would go with the DPP-4 inhibitor, and then very last choice would be a sulfonylurea. So that's how I tend to kind of progress with my patients. We'll start one medicine, wait 3 months, recheck the A1C, kind of see how it's going, and then talk about adding more medicine. Just continue escalating in that manner. And in general, you can get people under control. If the patient's halfway motivated to at least take the medicine, if not work on their diet and exercise, you can usually get people under control if you can find the right combination of medicine, and they'll actually take it. And then we move to insulin, which again is kind of my last resort for type 2 diabetes after all of the different combinations of oral medicines are not working or have failed or they can't afford them or whatever. I try to always do what's going to be the most convenient for the patient. So typically if I'm going to start somebody on insulin, I only start them on long-acting insulin first. Typically I use Glargine, brand name Basaglar or Lantus, or Toujeo or Semglee. This is the long-acting 24-hour insulin that doesn't have a peak. It just kind of creates a steady insulin level. And I feel like a lot of people want to start also by adding bolus insulin, but we find that you can get by sometimes just with the basal insulin. You don't necessarily have to make everybody go from 0 to 100 and start checking their sugar and taking multiple doses of insulin per day. I think they should be monitoring their sugar at home if they're on insulin. Other than that, for most patients, we don't have them start monitoring their sugar at home unless they're just motivated to do that, unless they want to do that. I think it's fine if they're only on oral agents and or GLP-1 to just let them take the medicine and then see how their A1C is doing without having them track it at home. But once you put them on insulin, they really need to have an idea of what their sugar's doing and understand the relationship between the insulin they're taking and what their blood sugar is going to do in response. You need to educate these patients about hypoglycemia. They should have an emergency glucagon kit available in case they drop so low that they can't take in oral glucose. So to me, the education component becomes even more important once you're putting somebody on insulin. So generally, we'll try the long-acting insulin by itself first. Of course, I'm talking about type 2s here. If you have a type 1, that may necessitate that you start with the whole basal bolus thing, so basal insulin along with bolus insulin. If we're just doing long-acting insulin for a type 2 diabetic, the official starting dose is 0.2 units per kilogram per dose, up to 10 units a day to start. A lot of people are going to need a lot more than 10 units per day, so usually we start them on 10. What I normally tell them, just as a quick instruction, is you can go up by a couple units a day or a couple units every other day on your insulin dose, and we want to see your blood sugars averaging around 140. That's usually pretty adequate. If we're talking about a type 1 patient that you're doing basal bolus with, I'll calculate the total daily insulin requirement as 1 unit per kilogram per day, and then do about half of that as the long-acting dose, and then the other half you're going to divide into short-acting insulin doses at mealtimes. As far as monitoring glucose, obviously if they're doing the basal bolus thing, they need to be checking their glucose multiple times a day so they can learn the pattern and figure out what's going to happen when they do this or that. With type 1 patients, once they do it for a while, they kind of get it. And I find that if you have a type 1 that's been dealing with this like their whole lives. You don't really have to tell them anything. They kind of know what to do. If we're talking about a type 2 patient who's getting started on insulin, unless we're having to do bolus, if we're just doing the basal insulin, I normally will just tell them to kind of randomly check their blood sugar just whenever they think about it throughout the day, so we can just sort of get an average of how it's running. If you can get somebody on a continuous glucose monitoring system, I think that's the ideal way to have somebody kind of learn to track their sugar and see what their patterns are. We're seeing that these are kind of more available to people. I think more people's insurance is covering them. The two choices are Freestyle or Dexcom. In my experience, the Dexcom system kind of works better. The sensors tend to stick better, and they are changed out every 10 days versus every 14 days with the Freestyle Libre. But regardless of which one you use, it's just a sensor that the patient sticks on their skin, and then it connects to their phone so they can just monitor their glucose as much as they want to. And another great benefit is that we as clinicians can get the reports and see the data from their monitoring system. It's actually pretty easy to set up an account. You just go to the Dexcom or Libre websites, create yourself an account, and then for Dexcom, there's a little code that you can give the patient. So they put in your clinic code in their app, and they can start sharing their data with you. For Freestyle, you send the patient an email with an invitation to join your clinic. And the information you get from these really is super valuable. You can see all kinds of different trends and patterns and reports, and you actually get recommendations from the system based on their glucose readings. It'll say, oh, it looks like, Sally's glucose is high around dinner time every night, so you might want to consider giving more insulin around this time. Or David's glucose is higher overnight, so you may want to think about increasing the evening insulin dose, whatever. It'll show you all these graphic representations of how much of the time the patient's in normal range and how much they're high, how much they're low, how many highs and lows they have. It's really a lot of information that you get from that. So I'm encouraging my patients, first of all, to use the continuous glucose monitor system if they can, and second, to share that information with me so I can look at it. And there have been some times where I've been looking at the patterns and go, oh, look, your sugar's way too high overnight, so we need to make a change here. Because that's information that you wouldn't normally get just from random finger sticks. So yeah, I'm a fan. They also have reader devices. At first, I didn't realize that that's just if you're not using your phone, do you need the reader device? So if you have a patient that does not have a smartphone or is worried about being able to use the smartphone app to do this, there is a reader device that you can also prescribe that they can use to read the sensor. In my mind, the ultimate perfect situation for an insulin-dependent diabetic is they have a continuous glucose monitor attached to an insulin pump that they wear around. And in our practice, we kind of draw the line there. We want these people to go to endocrinology and have them set up the whole situation with the pump. I'm pretty comfortable managing diabetes up until that level, even with new diagnoses. Some people will want to go see an endocrinologist, which is totally fine, but I don't feel the need to send all of my diabetics to endocrinology. I do sometimes see that people are kind of more compliant when they're going to an endocrinologist. And I think that's sort of the same phenomenon as with cardiology. They're not necessarily telling you anything different or using any different medicines than I would be. But when that comes from a specialist and endocrinologist, maybe it means more or hits home more than if it just comes from your friendly neighborhood nurse practitioner. I don't know. But I do have some people that just kind of want to go to an endocrinologist, and they tend to do great. They tend to really do a good job of getting their glucose under control. Again, the exception being if we want them to have a pump, I want endocrinology to set all that up. I have patients that have pumps that have been using them for a long time, and we just manage them. We just write the prescription for the insulin they need, and they kind of do it themselves, which is fine as long as you trust the patient to do that. But those things really work great. They allow the patient to really, truly manage their glucose and learn what they have to do and when. And a lot of times it's done automatically. If they sense more insulin's needed, it gives more insulin. So I think that really is the ultimate preferred situation for patients who really have to be on insulin. And typically those are going to be your type 1s. So that's a pretty good overview of the pharmacological choices for treating diabetes. Another big thing you have to think about with diabetes is comorbidities. Being diabetic is a cardiovascular risk factor, can cause kidney disease over time. It can cause liver disease in the form of what we're now calling MASLD, which stands for metabolic dysfunction associated steatotic liver disease, aka fatty liver. Uncontrolled diabetes can lead to peripheral neuropathy. Of course, you always want to be vigilant about doing foot exams for diabetic patients, because between the neuropathy and the effect on peripheral circulation, you get this situation where people are more prone to forming wounds on their legs and feet, and then also more prone to not being able to feel it and realize it. So you have these really horrible situations where people get these wounds that go on and on forever and ever. Amen. And of course, sometimes people lose their legs because of complications of diabetes. That's one thing that is very much in the public, maybe zeitgeist is the right word. Like a lot of people associate diabetes with losing your legs. And for whatever reason, it seems like a lot of people think that taking insulin makes you more prone to losing your legs. And I guess that's just the association of, grandma took insulin and she had to have her legs cut off. Therefore, insulin makes you get your legs cut off. So that's a very common misconception that we see that we kind of have to fight against. We like to see our diabetics every 6 months, and we have them come at 3-month intervals in between to check their A1C. Frankly, a lot of them don't do that. A lot of them just come every 6 months, which is fine as long as they're under control. As far as goals of treatment, obviously you want to keep the sugar as close to normal as you can. That's not always going to be possible, or it's not always going to happen. For younger, otherwise healthy people, you want to keep it really as low as you can. If you can get them below 6.5, that's fantastic. For most adults, if you keep them below 7, that's fine. For older adults, if you can keep them under 7.5 or even under 8, that's pretty acceptable. For older adults that are just in bad health, don't really have a long life expectancy, you don't really have to worry about it so much. The 85-year-old with the terrible quality of life and a ton of comorbidities, don't make them worry about their blood sugar. Eat the ice cream. It's fine. As long as they're not like getting DKA and having to go in the hospital and stuff. At a certain point, when you get to that point when you think, okay, this patient's not going to live very much longer, we need to do what we can to make their quality of life better, that's when you quit worrying about the blood sugar. For whatever reason, you're going to have some patients who are just not compliant, who just don't seem to care. And I don't really know what you do with those people. As far as I know, all you can really do is just kind of keep talking to them about the long-term complications of diabetes and why it's important to get the sugar under control, and just keep offering treatment. Maybe even like ask them, hey, I see you're having trouble managing your sugar. Is there some disconnect here? Is there something I can do to make this easier? Like, why are we not getting this? I know that some medical practices will fire patients who are non-compliant. We do not do that, but I don't have like the secret of treating those people. You just kind of meet them where they are, If you're not motivated to manage your diabetes, there's really nothing that I can do for you. So we just monitor and wait on the disaster to happen, which sounds bad, but I guess that's really what it comes down to. And of course, with diabetics, well controlled or not, you want to do everything you can to manage other risk factors that would contribute to cardiovascular disease. So when someone's diabetic, you want to be a lot more aggressive with keeping their blood sugar and their cholesterol under control, get them to stop smoking, encourage more exercise, etc. And you definitely want to be more alert for early signs of heart disease or kidney disease. In addition to just checking the BUN creatinine, you want to monitor the urine microalbumin or look at the urine albumin to creatinine ratio. And that'll give you a heads up if there's kidney disease coming down the pike. And then from a cardiovascular standpoint, I would err on the side of getting early stress tests or coronary calcium scores, or certainly if there are any symptoms that make you think there's a cardiovascular issue going on, you need to be encouraging them to go get their regular eye exams. And normally the optometrists and ophthalmologists are real good about sending eye exam reports on the diabetic patients. I'm going to leave the inpatient situation alone. Obviously, inpatient management of diabetes is very important, but that's a whole other deal that I don't deal with anymore. If you work in a situation where you're having to take care of people in DKA, or where you're having to manage diabetes when they come into the hospital for something else, that's a whole other can of worms that's kind of outside my wheelhouse these days. It does seem like most diabetics that go into the hospital for something other than DKA usually get taken off of their oral medicines and just put on basal bolus, sliding scale kind of situation while they're in the hospital. So sometimes in outpatient primary care, one of the things you will have to do is transition them back to their oral agents once they get out of the hospital and come back to see you for follow-up. Or if it turns out there's some reason where they need to actually stay on the insulin, then you already have a leg up if they've already been shown how to do that in the hospital and have already been doing that while they were an inpatient. So, all right, I think that about covers it. I'll put a link to the ADA Standards of Care 2025 in the show notes. If there's anything I forgot, if there's anything I said wrong, if you want to add anything, of course, just let me know. I hope this was useful for you. Thank you for listening, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients, in that order.